So welcome to this third installment of the series that we've been doing for interview preparation. If you haven't seen what it's all about yet, check out the first video here where we explain everything. But otherwise, we're going to dive straight in with an interview scenario. You can watch, pause it first to think about how you would answer it. Then you can learn from it, watch how the other person answers it, learn from their mistakes, pick up things that they do well, and then you can benefit from my model answers at the end and apply them to your interview practice to make sure that you get full marks when you come to your medicine interview. So I hope you find it useful, so watch and enjoy.
Josh, are you ready? Step into the gauntlet.
I wouldn't say ready, but yeah.
as you'll ever be, well, for now, at this stage. Okay, right. So spotlight's on you. Right, I'm going to read this out. You can have, I'm going to give you, you don't need to take the full minute, but I'm going to give you a bit of time to go through this, to gather your thoughts on this, because it's an MMI scenario, and I won't say anymore, okay? So, Miss Havisham, ages, sorry, I wrote this today. I didn't spell check very well, of course. Miss Havisham, aged 63, has metastatic lung cancer and lives at home with her husband. She has difficulty breathing, is on a morphine drip for pain relief. As her GP, you visit her at home. During the consultation, whilst her husband is out of the room, Mrs. Havisham says to you, I'm in so much pain and I'm such a burden to my husband. Please, can you help me to die? Okay, so how would you manage this patient and what are the ethical considerations here? Okay, so take your time. I'm not going to time a minute. I'm just going to give you as long as you need, but we'll go through then. You're not allowed to run away.
Sorry, last thing you wanted a dog barking in the middle of the question.
That's fine.
Okay, so there's a lot going on with the situation as a whole, whereas normally, obviously in a hospital setting or a GP, you're treating a patient and then moving on. This is obviously got some medical and social issues. And you have to sort of, you can't address it as a whole. I would say that you'd have to approach it as small individual tasks. So to start with, she's in so much pain. A patient with metastatic lung cancer is probably under a palliative team or a long-term care team. So you can start talking about better pain relief and treatment scenarios that would fit her. So you can come up with a plan that suits her pain and keeps her in a state that she's happy with. As for the burden to her husband, explain that there are a lot of services out there that do not cost, and for these sorts of situations are widely available in most boroughs, where you can get help with personal care, help around the house, even if it's just coming in, making a cup of tea in the morning, little things that will make a big difference to people in these situations. And a patient that's in so much pain that they're asking you to die, whereas obviously ethically we as doctors in the UK, doctors in the UK agree to do no harm, and euthanasia isn't something that is legal in this country. So we have to sort of make that very clear from the get-go and not give patients false hope. But we can also say what is wrong and how can we improve the situation to make it less unpleasant for her.
Okay. Are there any things that you need to assess? This patient's old, she's probably on a lot of morphine. Anything you need to consider before making, well, as part of your assessment?
So patient capacity to make their own decisions and acting in the best interests of the patient are the two priorities in that regard. So morphine, even if it is slow release, will have an effect on the cognitive ability of the person, and they can become confused, they can become disoriented. I've had patients myself who suddenly think I'm their mother when they've been given morphine, and it's about finding out what a baseline is for the patient. So talking to family, talking to the husband, carers who come in regularly, nurses that are part of the team, anyone who knows her, to get an idea of what her baseline is before we allow her to make any decisions that could have a long-term effect on her health.
Okay, good. So what maybe 2 or 3 action steps that you would take? I know you touched on them, but what are the 2 or 3 kind of high priority tasks to manage this patient? What were the main things you need to consider?
Treatment of the symptoms, so getting her pain under control, making her more comfortable, and treating any other symptoms that she might have, because obviously lung cancer can have quite a few issues with the breathing. Is there anything we can give to ease that? Social care, try and suggest to the patient and her family, because obviously if her husband is very proud, they're not going to want people coming in, but finding a way and wording things to suggest that it would be better for both the patient and the husband. And third would be probably trying to encourage the patient to be more open about how she's feeling with her partner, with her husband, because quite often in these situations I've seen patients thinking they are causing loads of problems, they're being a big issue, and a simple honest conversation with the family can completely alleviate that and remove a lot of emotional and psychological stress from the situation as well.
Okay, good. Any ethical factors or elements of medical ethics that are at play here?
So palliative care is a bit of a minefield with my history, because I've been a paramedic. We have got very limited ability to do things, whereas in reality, what the patient wants and what is the best interest of the patient are two very separate things often. So you have to weigh up, it's a balancing game. You have to weigh up what the patient is asking for, in this case, a release of pain, and what you can safely do for that patient. And in a way, the family as well, because they are in some way patients as well. And balancing that on sort of an ethical versus desire scale.
Okay. And do you feel like if she had all the pain relief that she could have, and she was still in agony, kind of fully alert, really in lots of pain, do you think that we could do more? Is there anything else we could do?
That's approaching a level of medicine that I'm not familiar with, so I wouldn't like to say. But in my experience, there are patients who have been put into, I'm not certain of the correct term, but a sort of medically induced coma, so that they are alive and unconscious and they pass without pain, which has been obviously a relief for the patient, but also it's much better for, and in some cases probably healthier for the family to see the patient at rest as opposed to in pain when they pass away.
Okay, perfect. Cool. Well done. Right, how do you think that went?
Not great. I think I waffled a lot. I didn't really address all the points that I wanted to well. I think the structure was lacking a little bit. I think I managed to integrate some good experiences with sort of evidence and reflection on what I would do next time. But yeah.
Yeah, no, I don't think it was bad by any stretch. Does anyone have any feedback? Johnny?
So I think like some of it was pretty good in terms of emotionally, you understood what was the scenario. I think just in the future, for just when you see ethics, just think of the 4 pillars. Do you know the 4 pillars of ethics? So you have autonomy, non-maleficence, beneficence, and justice, and then you have confidentiality. So when you have the scenario, just think how you can apply all 5 of those scenarios. So, for example, in that scenario, the patient would have autonomy over her care for what she wants, and you also have confidentiality. So she has confidentiality over her care, but at the same time, you can juxtapose that with saying that a doctor's role is for non-maleficence. So therefore, you're not, and by law, you're not allowed to. Obviously, as you said, by law, you're not allowed to like go and kill a patient, basically, because that's illegal in this country. So you can juxtapose the fact that she has autonomy over her care, and you can juxtapose that, with the fact that you do no harm, as the Hippocratic Oath. But also you can talk about what was the other thing I was going to say to you about? Yeah, so I've got that. And then, oh yeah, the other thing, I think the first thing just in ethics is just when the scenario comes, just assess the capacity, which I think he actually did answer one of the questions with the capacity. So just assess whether whether the patient is, available to, like her word is good for the doctor, basically, if that makes sense. So I think they're just the main things I'd say, just assess the capacity and then apply the 4 pillars of ethics plus the confidentiality element, but make sure you're using those words, because then then you can apply the scenario. The scenario will always apply to those 4 words in some way. So yeah.
Yeah, just to clarify a few things. So it's the 4 pillars of medical ethics: beneficence, non-maleficence, autonomy, and justice. And then the 3 C's are the 3 C's of medical law. So that's confidentiality, consent, and capacity. But yeah, that's right. And I don't know if you managed to look at Dr. Ryan's ethics kind of initial. We'll be doing loads of these ethical and all sorts of different talks, but Ryan did a kind of initial ethics talk, and he talks about the 4 C's, which I'm going to touch on now. But essentially, it's a framework of how you approach it. That's all it is. It's not so the 4 C's now I'm talking about. It's or the 4 pillars. Sorry. let me go back. 3 C's, the 4 pillars of medical ethics, is a framework for how you approach situations. Okay, so. Does anyone else have anything they want to say? Or I think so, Joe, go for it. Oh,
sorry, can you hear me now?
Yeah.
Hi, I just wanted to say that the way that you spoke was very kind of calm and assured approach. That came across very good, and I liked how you put in the fact that you used to be a paramedic into your answer and use that experience to answer the question as well.
Yeah, definitely. Do you still? I thought you still worked as a paramedic, Josh. Do you not? Okay, yeah. I would just say, in my work as a paramedic, I wouldn't say when I used to be, because, well, what you said in yourself, short, really. I'll come to you in a minute, Tijuana. Emily.
I was just going to say, and it's sort of half a question, I thought it was really good that you talked about social care, because the first thing that stood out to me was that she might have some mental health things that needed to be addressed here. But I was just wondering, is it better to specifically say mental health, or is it okay to sort of use other things like talking about social care or counselling? Or
yeah, well, I will come on to talk about that in a moment.
Okay, thank you.
To give away the game.
Sorry.
No, you're fine.
I was just going to say that you showed a really, really good understanding of your own limits. So when Ash talked to you about what would you do instead then? And you said that's beyond my medical knowledge. That showed such a good awareness of where you are in terms of your academic pathway. It was really good. I loved how you put that in there.
Yeah, the only thing I would add is just say I would call X, Y, and Z. I would call, maybe calls for a scene. Just if all else fails, just say I'd call for some senior support. You don't have to know who at this stage. Cool. Okay, let me share screen and we'll go through kind of the elements that are at play here. So, okay, so first we want to kind of get a bit more information. So you want to explore the issues. She is saying that she is, this poor lady, she's in pain, and her main concern is that it's traumatic for her husband or a burden on her husband. He may not feel it. Obviously, it will always be difficult for people who are caring for a dying spouse, but he might not see it that way at all. So explore it a bit more. And you said this really nicely, Josh, to encourage her to speak to people and to speak to family, to speak to her husband, to kind of discuss it. It's really important to say, this lady is in a very difficult situation, and just say that I would be as empathic or empathetic as possible. But yeah, her competence or her capacity, you have to understand she's on morphine, she's old, she's terminally ill. We need to check that she is not saying these things because she is not of sound mind. So that's really important to make sure that we've assessed. How long has she had these feelings? You know, you can understand somebody in that situation. If you might have caught them at a time when they're really fed up and they might just say these things. However, if it's something that's a bit more sustained, then it's a bit more worrying and something that we have to consider a little bit more. We need to see if she's a suicide risk, and kind of maybe consider treating for depression if it's more of a long-term thing. So because remember that the husband is out of the room, so you have a duty of confidentiality to her, even if you know it's in the situation that it is. So does she want to involve the husband? I would encourage her to talk to the husband. I've got a slide for kind of actions that you take, but I would encourage her to talk to her husband because, as I say, it might just be her perception and it might not be true at all. And then think about, obviously you don't need to know the details of this, but ask about what drugs she's taking. We want to find out a bit more about what drugs she's taking. Are they making it worse? Could we increase the pain relief medication? Because obviously getting patients out of pain is one of the first priorities. And then, so from an ethical point of view, like I say, if you haven't watched Dr. Ryan's talk on ethics, just I highly recommend that you watch it. So just approach every ethical situation, just the pros and cons or the fors and against, or just a touch on at least each of them. So from a beneficence point of view, we need to get the patient out of pain. We're trying to help them, and that's the best thing that we can do. Obviously, from a beneficence point of view, we can alleviate her psychological worries by exploring a little bit further. And if it's the case that her husband is actually not as burdened as she thinks, that will help in that sense. And yes, you completely correctly said that euthanasia in the UK is illegal. Despite your thoughts on it, you're still not able to help in that sense. So autonomy, is she competent, or does she have capacity? So her opinion should be respected. Obviously, if she's not of sound mind, then we need to weigh that up and kind of wonder if it's the condition or how much truth there is in what she's saying. But just the thing, there's probably not so much in the way of just in the justice corner here, but just to remember that regardless of whether she's terminal or whatever the situation is, even if she's lacking capacity, she's still entitled to the same level of treatment and care that any other patient would get. And of course, even if she's not of sound mind, she's saying she's in pain, that's something that you still need to pay attention to. Sajaya, did you raise your hand?
When you're answering the question and you want to talk about medical law, would you usually put medical law under, if you consider justice, then this, that, or would you put it under non-maleficence?
Sorry. So you're talking about the C's that we were talking about a minute ago?
No, so how euthanasia is illegal, so that's one of the laws. Wouldn't that be part of justice rather than non-maleficence?
As in, it's just, I wouldn't get too caught up with, okay, now I'm going to talk about the 4 pillars. Now I'm going to talk about law. These are the things. So in each of these areas, you might have a different thing to consider. It's not, do we talk about the law here or do we not? As in, ultimately, we have a duty of non-maleficence, and she's asking for us to help her end her life, and it's that is illegal. We're not. It goes against our code and it goes against our law. So, as in, from that point of view, we cannot do the thing that she's asking. The fact that it's a law is just happenstance. That just happens to be that it's a law, but I don't want you to get confused with I can talk about the law here and I can't. It's just I just want you to realize that the approach for ethical scenarios is to talk about these 4 segments, and the 3 C's of the medical law are something else. Okay. Does that clear that up? I hope I haven't confused that more. Is everyone clear on that? Because I really want to make sure that people are not confused on that. Everyone understand? Speak now or forever hold your peace. Cool.
Hi, can I ask a weird question?
Of course.
Then in that case, would it be okay if you give the patient like leaflets about having it somewhere else?
I would.
No, it's just out of like interest. I wouldn't say that, of course, but like.
I would steer clear of that. You're going to get yourself in a very tricky, sticky situation. I would leave it as it is illegal.
Is it legal? Like, I'm not going to answer it, but I just want to know in general. Like, is it legal that?
It's illegal in the UK. It's illegal.
But if you give
is it legal to
leaflets
recommend places?
Oh, okay.
So are you asking? What are you asking? Whether it's legal to recommend it?
Like, not recommend it, but if she really, really wants it after talking to like a consultant in her
I
caring
would steer
team.
well clear of that. I would just say, I wouldn't even say anything. I would just say, no, unfortunately, it's illegal in the UK and there's nothing we can do about that. I wouldn't. And if they say, would you point them in the direction? I would say, I'm not in a position to be able to recommend anything.
There's a paramedic at the moment.
Okay.
Yeah, there's a paramedic at the moment who's been suspended for a very similar thing to that, pending investigation. So most governing bodies take it very seriously.
What? So allegedly recommending that.
So it's not alleged. He's admitted it, but the whole scenario is a bit weird. You can go on the HCPC website and see all the active cases that are going on and why people have been suspended or struck off registers for different reasons. Mm-hmm. It looks like it's going to be okay and he's going to get his job back, but there's a lot of learning opportunities done for paramedic portfolios, paramedic papers and things done on it recently. Yeah.
So what was the situation that, I guess, there's a patient dying, he said, here are some countries that you can go to, or...
Yeah, so it was, I think it was in Lincoln. Mm-hmm. She's a regular caller for pain relief and palliative issues, and she'd been under a palliative team for months, and she was just in agony, and nothing they were doing was helping. And he suggested looking at, because she kept saying whenever her crew rocked up, she was getting like 2 ambulances every other day. She just kept saying, I just want to die. Like, I've got no quality of life. I'm stuck in this bed. I just want to die. And she was in a position where she was quite wealthy and she had the potential to be able to go and do it. And he's just sort of suggested it. He hasn't handed out literature or anything, but he's suggested it as an option. And it became an SI because she went and did it. And one of the family members wasn't happy about it.
Oh, crikey. Yeah. Yeah. So it was the family member that reported it. Okay.
Yeah.
All right. So I think that's your answer, Stephanie. Yeah, definitely not something that you should be in a position to. Just the stance is it's illegal in the UK. Doesn't matter what your opinion is on it. It's illegal in the UK, and you just leave it at that. Unless they really, well, I would say if they really press you, just say it's illegal. Therefore, as a doctor, I cannot recommend it. Okay. So where were we? So yeah, we've assessed her capacity, and yeah, we've done all this. Okay. Cool. Okay, and then the final bit is just the action that you take. So let's have a look. This is this symbol is to be running towards the patient to help, not running away from the patient. So pain. So yeah, obviously pain. It's the most unpleasant thing for her, is that she's in a lot of pain. So we need to be trying to do whatever we can to help get her out of pain. And as Josh rightly said, support. We can get a wealth of support from palliative care teams for their pain. We can get social care, Millen, respite care for the husband if she's worried about him. There's a range of services that we can offer. Okay, so yeah, encourage her to sort of speak up. You can't break confidentiality by talking to her husband, but you can encourage her to do it, and if she does it, then that might help. And then just offer reassurance. It's hard to reassure patients in this situation because they're suffering a lot, and of course, they know that they're going to die imminently, which is a hard situation to be in, but just offer reassurance that you're there, you're there to support and care for as much as you can within your ability, and that you'll use as much as you can from the support of the team to help facilitate that. Emily, yes?
You've mentioned Macmillan nurses there. I'm just wondering, are we able to recommend other charities and people
I would
that
just
they
say
can
charities in general, such as Macmillan, or yeah.
Okay.
You can. I would just say there are services and charities and sources of support. I think the point is that you've shown that you're thinking about support, not necessarily that you can name specific ones.
Just because that's relevant for me, because I work for one of those charities.
Oh, okay. Well, great. We'll say like, yeah, I actually work. Yeah, then that would be good to talk about it and say like, I actually work for one of the charities where we do this, this, and this, and yeah, I know firsthand that that's really helpful for patients.
Okay, great. Thank you.
No problem. Okay, right. So that brings us to the end. Oh, sorry, right to die. Just a bit from GMC. So where the likely progression of a patient's condition is known and their death is seen as an inevitable outcome, it is important to ensure that the patient's palliative or terminal care needs identified and met appropriately. This is just saying that even if they're terminally ill, we still need to treat them just with the same level of respect and care that we do for any other patient, which kind of goes without saying.